Good afternoon, everyone. My name is Haley Aka, and I'm a policy analyst with the Health Policy Institute of Ohio. Thank you for joining us for the Access to Care Work Team meeting for the Strategic Action Plan on Aging. This is our fourth and final work team meeting in this round, and we are so thankful for your participation, particularly those of you who have joined us on more than one of these calls. Thank you so much for your engagement in this work. We're glad to be able to convene this work again in the midst of the pandemic and want to express our appreciation to all of you for the work that you're continuing to do to combat COVID-19. We also appreciate you being here to contribute to the Strategic Action Plan on Aging during this time. Before we dive in, I'm just going to give us a few housekeeping items. For now, everyone is in listen-only mode to reduce background noise. We do want this to be an interactive meeting though. So if you have a question, feel free to type it into that question box. There will also be opportunities for discussion throughout the webinar. So during those discussions, please raise your hand using the hand icon on your screen and we'll unmute you. Keep in mind though that if you've muted yourself, you'll need to unmute yourself as well. If you're joining us by phone, please make sure that you've entered your audio PIN. You need to log into the webinar first before calling in order to receive your PIN. Both the slides and a recording of today's work team meeting will be posted on the SAPA Advisory Committee page on the HPIO website. You can find that by going to hpio.net and clicking on groups. HPIO is facilitating development of the Strategic Action Plan on Aging, or the SAPA, under contract with the Ohio Department of Aging. We're joined this afternoon by Carmen Clutter with the Elder Connections Division at the Department of Aging, and you'll also be hearing from my colleagues Zach Reet, our Director of Data Management and Analysis, as well as Carrie Almasy, a fellow health policy analyst. As a reminder, HPIO is a nonprofit, nonpartisan organization whose mission is to provide the information and analysis needed to create evidence-informed health policy. We are convening this group to provide ODA and HPIO guidance throughout this process of developing the SAPA, as you see here. Before we provide you with an update on the process and timeline for this work, we have a little poll question for you. Alana is going to throw up on the screen. How much of this process, the SAPA process, do you remember? For those of you who this is their first work team meeting, it's been a long time since we've spoken and been together to do this work. For those of you who have been on a work team meeting this week or last week, you might have a little bit of a heads up on this, but we just want to get a sense of where people are at and what they remember about the SAPA and where we are in this process. So go ahead and vote. All right, I think we're ready to throw that poll. Great, looks like some of you remember everything, which is fantastic. Maybe you were on a meeting earlier this week or last, and then quite a few of you need a little bit of a refresher, which we are happy to provide. So thanks for joining us here and for answering that poll. All right, here's the agenda for our meeting today. Let's see that. And here are the objectives for today's meeting. By the end of today's webinar, we will have the guidance needed from all of you for the prioritization of desired outcomes and indicators for the access to care area of the SAPA. And with that, I'll hand it over to Carmen to provide more context on this work.
Great, thank you, Haley. Good afternoon, everyone. I first want to start off by welcoming all of you to our fourth SAPA work team meeting. For many of you, you've been a part of one or more of our prior work team meetings, so welcome back. We're really happy to have you back with us today. And for those of you who are brand new to our work team meetings, thanks for joining in. I do want to take some time and just thank you and acknowledge your time commitment to today's conversation, as well as towards the development of the SAPA. We really do appreciate that. And we know, especially during the time of the current pandemic, that everyone's schedules are a little bit more tight. So thank you for accommodating the time with us today. On behalf of the Ohio Department of Aging, I also want to share our excitement for the opportunity that we have to work with the Health Policy Institute of Ohio to help facilitate the development of the Strategic Action Plan on Aging, the SAPA, and we're thrilled that each one of you has committed to helping with those efforts. Before we get started, I do want to take just a few minutes to revisit the purpose of the SAPA. I think maybe some of us on the line could use a little refresher based on our poll results today. So when addressing community conditions, or what we also call social drivers of health, it's really important that the unique needs of older adults are also considered. Efforts to address health inequities across the state need to be both intentional and also inclusive of older adults. As a network, we have an opportunity to address many of these social drivers, including access to care, which we'll talk about more today. The SAPA will build on the current state plan on aging and also align with Ohio's 2020 to 2022 State Health Improvement Plan, also known as the SHIP, which was recently released. The SAPA will also highlight priority topics and outcomes to answer the question, what is most urgent to achieve well-being for older Ohioans? It will include prioritized and specific action plans that state and our local partners can use to ensure that all older Ohioans achieve their full health potential. Achieving the SAPA vision that Ohio is the best place to age requires a very coordinated approach to implementing strategies within the SAPA and the SHIP. While today is our fourth convening of our SAPA work teams, a lot of work has already gone in to this process, and we've already completed some of our milestones. So during the second advisory council meeting, HPIO introduced the summary assessment and walked all of us through its key findings. Since that meeting, the summary assessment of older Ohioans was published. It was published on Friday, June 5th, and it provides a comprehensive picture of the health and well-being of older Ohioans, and we can use this to inform the development of the SAPA. The summary assessment itself really addresses two main questions. The first question being, what are the biggest health and well-being strengths and challenges for older Ohioans? And two, what factors impacting the health and well-being of older Ohioans are most important to address? Also, during our second advisory meeting, we all engaged in dialogue to start prioritizing subtopics for the SAPA outcomes and factors. And then following that meeting, advisory committee members completed an online survey to then independently prioritize subtopics within the priority outcome and factor topic area. So thank you so much for your feedback and your response. And through our conversations today, HPIO will walk us a little bit more through these survey results and the decisions that were made from that survey, as well as kind of the next action items that we'll be taking on that. So before I hand it back over to HPIO, I do want to jump into just a few key reminders and really set the stage to remind us all about the importance of prioritizing outcomes and the need to be very concise in our approach and strategy. So the SAPA needs to include a narrow set of priorities with SMART objectives. Those are items that are specific, they're measurable, they're attainable, they're realistic, and they're timely. In addition, these objectives need to also include establishing performance targets, identifying priority populations, and as well as selecting evidence-informed strategies. So we need to be able to assess and report progress in a meaningful way. We need to be able to identify the magnitude, the severity, and inequities of the problem. Of course, we want to ensure alignment with the state plan on aging as well as the SHIP. And we also really need to make certain there's a potential for impact. So there's the availability of evidence-informed strategies to address the subtopics, both at the state level and at local levels. So again, thank you for joining us today. We're thrilled to have you here. I hope you all will be very engaged in our conversation over the next 2 hours. And I think that's about it. I will pass it back over to Haley.
Great. Thank you so much, Carmen. And we are very excited to continue this work on this project and look forward to creating that actionable plan that improves health and well-being of older Ohioans. All right, all. Working on getting my next slide going. Perfect. Maybe not perfect. Great. Okay. I shared this slide with you all before, but now that you've had more context on the work, I want to share it with you again, that this is the role of the advisory committee that all of you are a part of. In creating this advisory committee, we were very intentional in reaching out to a wide variety of partners and sectors. We have 61 individuals participating on this advisory committee, representing all of the sectors that you see here on the screen. We were also happy to see strong participation in the work teams. Here you see the number of advisory committee members serving on each of our work teams. And later this afternoon, we'd like to get some feedback from you on stakeholders that we can reach out to for additional expertise regarding strategies and target setting in each of these areas. So be thinking about that, and we'll circle back there. I want to share an updated SAPA timeline with all of you. As you know, as Carmen just shared, we completed and submitted the summary assessment of older Ohioans earlier this year to ODA, and that has now been released. You can find a copy of the summary assessment in the handouts tab here on GoToWebinar. It's also posted on the ODA website and on the HPIO SAPA page. We will hold work team meetings like this one and conduct key informant interviews throughout the end of this month and through July. And during that time, we'll also be working on recommendations to strengthen data collection and evaluation across the aging network. Given delays to COVID-19, we now expect that the SAPA will be completed at the end of September. And we will be assisting with dissemination of the SAPA and developing some technical assistance materials to inform SAPA implementation throughout the months of September and October. The summary assessment of older Ohioans provides a comprehensive picture of the health and well-being of older Ohioans, drawing upon multiple sources of data and information to inform development of the SAPA. Through the summary assessment, we identified 6 key findings that reflect the current state of health and well-being of older Ohioans. We discussed those key findings and data in the summary assessment at our last in-person meeting in March. And the feedback we received from you all at that meeting was used in development of a survey to prioritize topics to focus on in the SAPA. As Carmen described, the SAPA will be a prioritized and specific action plan that state and local partners can use to ensure all older Ohioans achieve their full health potential. The purpose of the SAPA is to build on the State Plan on Aging and align with the SHIP to answer the question, what are the most important priorities to focus on to achieve health and well-being for older Ohioans? The process to identify those priorities is being informed by the State Plan on Aging, the State Health Improvement Plan, that's the SHIP, the findings from the summary assessment of older Ohioans, as we've mentioned, and those key informant interviews and your input as part of the advisory committee and priority work teams, all of that stakeholder input that we're gathering from you all. This advisory committee, along with members of the priority work teams and key informants, will be instrumental in prioritizing the topics to focus on in the SAPA. So that includes setting SMART objectives, which, as Carmen mentioned, are specific, measurable, achievable, realistic, and time-bound. Informing performance targets, identifying priority populations, and identifying evidence-informed strategies that can lead to improvement on the set of objectives that we agree on. Our work today will get us another step closer to identifying each of these components for the SAPA. Here's the conceptual framework that guides this work. It was developed with your input to define the scope and focus of the SAPA. And in just a minute, we'll be sharing how this conceptual framework was further refined based on the online survey feedback that you all provided. But before we get there, I just want to give you a chance to ask any questions you might have about the process or how we got here. So if you have any questions, you can go ahead and type those in the question box or raise your hand, and we're happy to take those at this point. I'm just going to give a minute to see if anybody has a question or a comment.
Haley, this is Zach. I just wanted to jump in and sort of echo your thanks for people participating, and also to encourage all of the participants to please feel comfortable to make your voices heard today. We value your opinions and need your expertise, but if we don't hear from you, we can't have those things. So please type your questions into the questions box, draft an email to us if you've got several thoughts you want to send to us, or raise your hand. And in fact, that's preferable, raising your hand so that your colleagues around the state can hear your thoughts. So sorry for the interjection, Haley. Just wanted to get out that it's really important to us to have good participation.
Absolutely. Thank you, Zach. And thanks to all of you again. I totally echo what Zach said, that we're so appreciative of you being here and sharing your expertise with us. And we look forward to hearing from you as the meeting continues. I'm going to move on to our survey results so that you all can see what that looked like once my power returns so that I can change the slides. Wonderful. Okay. So we're going to do that prioritization survey section. Great. So today we're focused on narrowing down and prioritizing the outcomes that will elevate in the SAPA. And again, just like I shared, these are the sources of information that we're using to draw upon to set SAPA priorities. And at this point in the process, we're really focused on that last piece, which is getting input from all of you on our advisory committee and in our priority work teams. So we're doing that through a couple of avenues. We started back in March at our last in-person meeting discussing what topics should be prioritized in the SAPA. We then sent out that SAPA prioritization survey in May, which collected feedback from all of you. And now, of course, we're in our work team meetings where we're getting into much more detail about what should be prioritized. Okay. What we'll do first is share the results of the prioritization survey so you can see what that looked like. And then we'll head into our task for today, which is to discuss the best subtopic, the best ways to narrow down the community or the access to care subtopics even further to a set of measurable outcomes that can be tracked in the SAPA. Again, we use the feedback from small group discussions on March 2nd to craft the survey, which we sent out on May 13th. The survey went out to the entire advisory committee and a total of 36 people were able to respond to that. As a reminder, these are the criteria that you were asked to consider as you prioritized subtopics in the survey, and they continue to be really important as we continue to narrow today. So I'm going to go over those really briefly. We want the outcomes that we elevate in the SAPA to be measurable, meaning that we can track our progress on these indicators over time. We also want to be addressing the most important issues facing older Ohioans. That's that nature of the problem consideration. We should align with other state level plans whenever we can, including the State Health Improvement Plan. We want to choose outcomes that we can impact through evidence-informed strategies. And then finally, for the priority factor areas like access to care, we need to be thinking about how these outcomes that we prioritize connect to our outcome areas, social connectedness, population health, and preserving independence. So for example, how do our priorities in healthcare coverage and workforce capacity connect to priorities related to falls or social isolation? We want to make sure that those connections are there. With those criteria in mind, here were the survey results for the access to care subtopics. It was a difficult task narrowing these subtopics down in the survey, since you started with a list of 7 potential subtopics, each of which were really broad, and you were asked to prioritize just your top 3. You all did that, and so we're going to focus on these top 3 subtopics for discussion today: availability and affordability of long-term home and community-based supports, workforce capacity, and healthcare coverage and affordability. Our goal is to narrow each of these areas down to one desired outcome to address in the SAPA. So one outcome for each of these subtopics in the yellow box. Before we do that, we want to provide an update on how the priorities are shaping up in the other areas of the SAPA. For those of you who haven't been on prior work teams and haven't seen this, we want to give you a full context of what's been going on. At this point, all the other work teams have met and provided their feedback on these priorities. And so these are the selected outcomes. Although the selected outcomes are still a work in progress, we want to give you that update. So for social connectedness, see the priority outcomes are social isolation and volunteerism, in population health, cognitive difficulty, depression, and high blood pressure, and for preserving independence, chronic pain management, and falls. Moving over to the priority factor areas and community conditions, that group has prioritized financial stability, housing quality and affordability, and transportation access. And health behaviors will be focusing on nutrition and physical activity. So we'll be doing the same thing, getting to those narrow set of outcomes for access to care here today. Again, here is how all of those priorities fit into the overall SAPA framework, getting us to our overall goal of all older Ohioans achieving their full health potential. I'll pause here again to see if there's any questions on the process, on the survey results, how we got to where we are. I've not seen any questions pop up as I've gone, so I feel like you're tracking with me. But if not, throw a question in the question box or let us know if you have a question, and we'll address it. But if not, I'm gonna pass it over to Zach, who's gonna walk us through some of the nitty-gritty considerations for the work that we're gonna get into today. Go for it, Zach.
Thank you so much, Haley.
Mm-hmm.
So as you've heard from Haley and from Carmen, prioritizing is a very difficult and an important part of developing an effective action plan, a workable action plan. And today we're going to be prioritizing outcomes in each of these subtopic areas related to access to care. We're going to be using the same criteria to prioritize the outcomes as we did for the subtopics. And today, myself, Haley, and Carrie are going to be giving you information on the first, fourth, and fifth considerations for each of the outcomes. As we describe each, we're going to let you know whether we've identified a state level indicator to track progress and whether that data can be disaggregated. And just as a reminder, the ability to disaggregate that data allows us to identify priority populations to target resources toward. With regard to potential for impact, as you've heard, there should be evidence-informed approaches to addressing the outcomes that we select. And today we'll provide examples of those strategies when they exist. And then as we're discussing each one of the outcomes, we want you to be considering the connections to the priority outcomes, the priority health outcomes that have already been selected. And as a reminder, those are here: social isolation, volunteerism, cognitive difficulty, depression, high blood pressure, chronic pain management, and falls. Now I'm going to give a little bit of background information on each of the data sources that we pulled indicators from. Before I do that, I just want to tell you how we identified the state level indicators that we're going to be sharing with you today. After you all prioritized subtopics in the survey, we went back to the data sources that we used to assemble the summary assessment of older Ohioans. We consulted with our partners at the Ohio Department of Aging and also many of you to identify these state level indicators. All of that said, there may be sources that we've missed, and there may be indicators that are more appropriate to measure the outcomes we're talking about than what we propose. Please, please, please share that information with us by either typing it into the question box or following up via email. Many of you have done that, and it's been extremely helpful through these first work teams, so thank you for that. Excuse me. So the first data source that I'll tell you about is the AARP Long-Term Services and Support State Scorecard. This is really a core report for this area of the SAPA and a source of many of our indicators. It's produced periodically about every 3 years. And we have learned that the release of the 2020 Long-Term Services and Support Scorecard has been delayed by COVID-19, but we have not been able to get a specific answer on when release has been delayed to, so that is a consideration. The report provides really in-depth analysis on topics relevant to older adults. But because that analysis is in depth, some of the indicators can be difficult to understand without quite a bit of context on the issues. We have selected several indicators, as I mentioned, from this report, so you'll be hearing about it more. One disadvantage of this source, however, is that none of the data is disaggregated, so we can't look at outcomes for specific groups. The next sources we'll look at are America's Health Rankings Senior Report and Kaiser Family Foundation State Health Facts. These are secondary sources with analysis of data that's related to health and health factors, and that includes behaviors, environments that impact health, clinical care, cost, and affordability of health care. The America's Health Rankings report is updated annually, and State Health Facts is updated regularly as new data becomes available. When possible, both of these sources do disaggregate data as it's available. Unfortunately, however, many of the indicators that we're going to be discussing today, again, cannot be disaggregated. The last source that I'll describe is the Ohio Medicaid Assessment Survey. It's an Ohio-specific survey that collects information about health status and factors. Data is collected for this survey every 2 years, but not for all of the indicators. Data from the source can be very easily disaggregated by sex, age, race and ethnicity, income, disability status, county type, and insurance type. And so that's a major advantage of this source. Another is that we can get to the 60 and older age group to better align with the Older Americans Act, whereas many of the other sources only allow for cutting off at 65. All right, and excuse me, in the spirit of HPIO forums and our physical activity breaks, I'm going to be standing up to present these next slides here in my office bedroom, and I encourage you to do the same to get some physical activity into our days. So here are the desired outcomes that we've selected for availability and affordability of long-term services and supports. The first two focus directly on the affordability of LTSS. The next two outcomes deal with the supply and access to specific types of housing and services for older adults. And then the last two outcomes deal with the use of nursing homes and home and community-based services. In general, the indicators that we've identified to measure these outcomes are specific, and they do pretty well represent the issues that the SAPA is going to address. And that's different from some of the other work teams where the indicators may not have exactly lined up with the outcomes or the needs of older adults. And I think that'll become clearer to those of you who have participated in other work teams as we move forward. All right, so the first outcome we'll look at is improve long-term care affordability. Both of the indicators for this outcome come from the Long-Term Services and Support Scorecard. The first compares median nursing home private pay cost to median household income for adults over the age of 65. And then the second looks at the number of long-term long-term care insurance policies that are in effect. And long-term care insurance is one specific strategy to deal with long-term care affordability. In our review of evidence-based strategies, we did not identify any strategies that are rated specifically to improve long-term care affordability. So if this outcome is selected, we would really need to rely on your help to identify the best and most applicable set of strategies. And I just want to make a quick note that when we say we have not identified any strategies, what we've done is we've gone out to evidence registries like What Works for Health and some resources from the Administration for Community Living and looked at the strategies that are out there and the outcomes for which they've been evaluated as effective. So this is a literal read of research. There may be innovative programs, things that have been recently evaluated that haven't been integrated into those registries, and that's where we'll be relying on your expertise to bring them in. The next outcome we'll talk about is improving home care affordability. So before we looked generally at long-term, now we're looking specifically at home care affordability. Again, this indicator compares the cost of home care to median income for older adults. And again, we didn't find any strategies that were directly related to reducing home care affordability. We did, however, identify several home-based strategies that do improve outcomes and reduce utilization for healthcare services. Research supports that providing older adults with housing and services that meet their needs as they age improves outcomes for older adults and quality of life. And our next outcome looks at the supply of assisted living and residential care units. And the indicator compares that to the population ages 75 and older. It's notable that this particular outcome is very closely tied to the housing outcome that was selected by the Community Conditions Work Team. And that outcome was called Improve Housing Quality and Affordability. So very, very close connection there. When we reviewed evidence registries, we didn't turn up any strategies that are specifically rated to increase assisted living and residential care units. However, given the close connection to the housing outcome, many of the strategies that we might identify for increasing the supply of affordable housing generally could be potentially targeted to addressing the supply of assisted living specifically. All right. Research also says that hospice care is an effective strategy for improving patient, system, and spending-related outcomes at the end of life. And this indicator comes from the America Health Rankings Senior Report and looks at the percent of people who die with Medicare who were enrolled at hospice at the end of their life. Again, we didn't identify any specifically rated strategies for increasing hospice care. So here again, we'd be relying on your expertise. Also notable for this outcome and this indicator, Ohio really does well relative to other states on this indicator. In 2017, Ohio was ranked number 6 out of 50 states, number 1 being the best, right? So Ohio was up there. And again, we didn't identify any strategies, but we know there's things out there that people can do, like having advanced directives in place. So we'd certainly be looking to bring in those strategies as well. Okay. I just saw a question pop up, which I am going to hold on to answering until the end of, until we get through these last couple of outcomes, but please do be typing those in as you are thinking of them. So the next outcome we'll look at is increased patient-directed transitions out of nursing homes. Both of these indicators come from the long-term services and supports scorecard. And the first measure is nursing home use for people with low care needs. And the second measure looks at successful transitions back to the community for people who had a stay in a nursing home of 90 days or more. We did identify 2 strategies that improve nursing home care and transition outcomes. And the first listed there focuses on case management for older adults, while the other focuses on systems integration to support older adults. The last outcome I'm going to discuss broadens the focus on to community-based services from that more narrow focus on transition specifically from nursing homes to community settings. The indicator here comes from the long-term services and support scorecard, and it reflects how often a new long-term services and supports user first receives services in the community. Here again, we identified the same strategies as we had for nursing home transitions. And in general, we know that systems coordination and case management have been shown effective at improving outcomes in this area. So now we're going to move on to a discussion of those 6 indicators related to the availability and affordability of long-term services and supports. Please type any questions or comments into the questions box, or better yet, raise your hand and we'll unmute you so that your voice can be heard. And we had one question from Lark. It isn't just the number of long-term care insurance policies, but also the quality of the products, harder to measure. So Lark, I'm assuming that is in relation to the long-term care affordability indicator about private long-term care insurance policies. As I was writing up my notes to present this slide, I included some things about long-term care insurance being a product that many people have trouble affording. It's an expensive insurance product. And we also know that in the research, there is a lot about quality, how quality has changed and how this specific segment of the insurance market is changing. So all great points. Again, these indicators are examples, and we'd be working with work team members to nail these down between now and the next work team meeting. It's a great point, Lark, very well heard. I'm not seeing any other questions coming into the questions box. Alana, do we have anybody's hand up? I don't think so.
Zach, will you go ahead and put up the outcomes again, the list of outcomes?
Yeah. Thanks,
Folks
Haley.
can see those, yeah. Nice.
Okay. I'm gonna go to this one at the end here so that. Okay. We have a question from Teresa about, can you explain why you would use the AARP Long-Term Services and Support Scorecard for improving access to community LTSS instead of the Ohio Medicaid data? Teresa, the reason we've got the indicator up here from Long-Term Services and Support Scorecard was because that was the source that we used in the summary assessment of older Ohioans. And that report allows us to compare Ohio's performance to other states. All of that said, Ohio Medicaid data may be a better source for that particular indicator, and we could certainly switch it for the final report. So
We have a
not
hand.
I see a hand up, Zach. So I think it's Orion, and I'm gonna unmute you. Orion, if you'd like to go ahead, we can hear.
So just on the question about using the Ohio Medicaid number versus the AARP study number. Some of the AARP number, I think, includes people that are not Medicaid. It's the question as it relates to assisted living and home care services.
If I recall, it was a balance for Medicaid LTSS users. Alana, do I still have control here?
You do. It's just kind of
Okay,
split between us. Go ahead and go back if you need to, Zach.
I'm trying to there. Yeah, so it is Medicaid aged disabled LTSS users.
Okay, thank you.
You're welcome. All right, not seeing any other questions. We do have one sort of technical detail glitch to deal with. We would love to be meeting with you all in person, but the system we're using to meet with you virtually to keep us all safe only allows us to have a poll with 5 options. So I need somebody to please volunteer to type into the questions box or speak up and tell us which of these outcomes we should remove from the list before we vote. And then we'll give an opportunity for anyone to, of course, voice a strong disagreement with that.
Zach, while they're doing that, I see a hand raised from Lark, so I'm going to unmute her and let her speak. Lark, if you'd like to share your comments.
Yes. And I went right out of my head when you said, I'm sorry.
Oh no.
Busy trying to raise my hand. I think it had to do with, I know what it was. I'm wondering about the use of the balance between home care and nursing home care, because that's not necessarily showing up in these desired outcomes. And that's what has been a measure for years, and also I think is easily measured with other states, or at least it used to be. I do know that they used to publish that regularly, and a little less so now that managed care, the MLTSS is widely used in the country, but it does seem like a measure and also an outcome that having a better balance with more Ohioans getting home care versus nursing home care. And I'm just throwing that out there to see what you guys think about that.
Lark, could it be, well, I'm looking at this improve access to community-based LTSS. Could we label that improve access to home and community-based LTSS, and then have the indicator as the balance of home to community-based?
Yeah, I think that would work.
Okay, so it's really that missing the home and community-based in this
It's
outcome
missing the
number
home and
6.
community-based, and it's also, I guess the indicator would be how much we have moved the needle from the amount that we're spending, at least in Medicaid, on nursing home care versus what we're spending on home and community-based care.
So it would not only be looking at the percent of people in those services, but the spending on those services as well.
Yeah, and they used to measure both of those things. Yeah.
Got it. Thank you.
Yeah,
And that's
thank you.
certainly something we could look into.
Okay.
Zach, we do have another hand up.
Okay.
Orion, I think I see your hand up, so I'm going to go ahead and unmute you if you'd like to go ahead and speak.
Just to comment that community-based long-term services and supports includes home care as well as some degree of intermediate care, assisted living kind of things. That it's the distinction between skilled nursing facilities and community-based care is the distinction. So to make sure that when we refer to community-based, that includes it's home and community-based. So day treatment, adult day programs, even assisted living facilities are counted as community-based, home and community-based care, as a distinction from skilled nursing facilities, which is the traditional nursing home.
Okay, thank you. Any input on which outcome we should remove? Okay. When we
Maybe we should
prepare
just
the
ask,
poll, I'm sorry?
maybe we should just ask everyone. If everyone in the question box would put in their vote for what to remove, that would be really helpful. We won't make any of you say it out loud.
There you go. Thanks, Haley. I didn't mean to put anybody on the shot.
Great, we're seeing some coming
I'm
in.
seeing a little bit of agreement here.
Mm-hmm.
Okay. All right. Well, I'm seeing some agreement for removing increased access to end-of-life hospice care. Does anybody strongly disagree with us removing increased access to end-of-life hospice care? Okay, so that's 4 votes for hospice care that have come in. So seeing no hands urgently being raised to
Advocate for hospice care.
Right. Not that hospice care is unimportant,
No.
part of this network. But all right, so Alana, I need you to please rework our poll, and please hang with us for a moment, attendees, while we deal with the limitations of our systems. Alana, I'm going to ask you to put improve long-term care affordability back into our poll and remove increase access to end-of-life hospice care. As Alana does that, I will be standing up and marching to continue our tradition of physical activity. I don't know about you all, but reminding myself to remain physically active while working from home has been a major challenge.
And he's not kidding. He's really doing that. Don't think he's talking a big game. He's really marching. I believe it.
Yeah. One of my favorite things about the physical activity breaks in our forums is the smiles that kind of break out over the crowd after, even just 10 or 15 seconds of moving around and then kind of laughing with your colleagues about it. It's fun.
Moving, being a little bit silly.
You got
We
it.
need that. We need it.
All right, so Alana is going to throw this poll for us. Please go ahead and vote. Yep, it looks like we've got all the options up there we agreed on. All right, let's go ahead. We got just a couple more people who haven't voted. We'll give you another 10 seconds here. I know you're probably finishing up that last set of squats. Could please vote.
I think we're good. You ready?
All right, I think we're good. Go ahead, Alana. Not complete consensus, but a majority voting for improve access to community-based LTSS. Thank you. I know that was a lot to get through and appreciate your input. Now I'll turn it over to my colleagues to go through the next topic.
Thanks, Zach. Hi, everyone. This is Carrie, and I'm going to walk you through the desired outcomes for the healthcare coverage and affordability subtopic. You are welcome to remain standing, do whatever sort of physical activity is necessary to keep that blood flowing. So first, we will discuss the pros and cons of each of the desired outcomes you see here. They focus on insurance coverage, prescription drug coverage and affordability, out-of-pocket spending, and unmet healthcare needs. As we go through these outcomes, keep in mind that the vast majority of older Ohioans are already covered by some type of health insurance. The uninsured rate for those 60 and older in Ohio is only about 2% in the most recently available data from 2017. However, we also know that cost and affordability remain issues for many older Ohioans. That's why the outcomes that reference cost, like the one around prescription drug coverage and affordability, are really important. For the increased health insurance coverage outcome, we have a more narrow indicator that measures the uninsured rate and a broader indicator that measures the type of insurance coverage among older adults. Both of these indicators come from the Ohio Medicaid Assessment Survey, though we do have additional health insurance coverage data from the census. They can both be disaggregated by sex, race, ethnicity, disability status, and income. These are a few policies and programs that are proven to impact health insurance coverage. They include health insurance enrollment outreach and support, maximizing Medicaid enrollment for eligible individuals, especially dual eligible older adults, using existing resources such as community health workers to raise awareness of enrollment assistance, and policy changes like mental health benefits legislation that would expand benefits. On the flip side, we have two indicators around prescription drug coverage and affordability. The first measures enrollment in a prescription drug plan. Unfortunately, this indicator has been discontinued from the 2020 America's Health Ranking Senior Report. So if we decide to choose this particular outcome, we'll need your input to identify another good indicator that measures prescription drug coverage. The second indicator measures prescription drug expenditures and comes from the Kaiser Family Foundation's State Health Facts. I do want to note that this indicator cannot be disaggregated because it measures per capita expenses among the greater population, so it's not specific to older adults. To increase coverage on an individual level, we could adapt many of the same strategies that we highlighted to increase health insurance coverage to focus on prescription drug coverage. This includes maximizing Medicaid enrollment, using community health workers for enrollment assistance, etc. There are also strategies that impact prescription drug affordability on a broader scale, such as value-based purchasing for drugs. This model uses payments, it bases payments on improvements in patient outcomes. So it's slightly different than a traditional payment model. Another way to increase healthcare coverage and affordability would be to reduce out-of-pocket spending. Here we have a composite indicator pulled from the same source as the prescription drug expenditure metric that we just discussed. We were able to target spending categories that are the most salient for our population, including prescription drug spending, nursing home care, and home health care. As a reminder, this indicator cannot be disaggregated and is not specific to the older adult population. Also, there is a bit of a data lag as the most recent data available is from 2014. Out-of-pocket spending could be impacted in a number of different ways. These are just a few examples we have listed here. Evidence has shown that reducing out-of-pocket costs for things like preventive services, prescriptions, and tobacco cessation leads to positive health outcomes. There's also evidence that providing incentives or rewards for preventive care, like vaccines, has been effective. To measure reducing unmet healthcare needs due to cost, we look to this Burfus indicator of people ages 65 and older who could not see a doctor because of cost. We can disaggregate this indicator by sex, race, ethnicity, income, and education. Although through our review process, we did not identify any evidence-based strategies to reduce unmet healthcare need due to cost, a natural place to go would be to increase health insurance coverage, but we know that that's not really sufficient for many who are covered but still have affordability issues. So if we select this outcome, we would want to work with you to identify strategies that would create impact for those individuals. So now we'll have a moment to discuss these outcomes before we vote to prioritize. Again, just remember to click the icon to raise your hand and we'll unmute you if you would like to share. So of the outcomes that we went over in this section, which do you think is the strongest? Which will have the biggest impact on healthcare coverage and affordability for oldest adults?
Like to encourage some of you who have been on the call and maybe not chimed in or been on several calls and not made your voice heard to please consider chiming in.
I see we have a hand raised. Alana.
Hello, Marie. I'm going to unmute you if you'd like to go ahead with your comments.
Thank you. Hang on. Now I've created a feedback problem. Hang on. Okay. Two things. One is I have not only the attention span of a gnat, but the memory of a gnat as well. So I am paying attention. But if it's possible to share your slides so that I can like scroll back and forth on them myself when I'm trying to remember what I just learned, that would be amazing. Because now I'm going to just ask you anyway. Can you remind me how good the indicator of out-of-pocket spending on healthcare is?
Absolutely. Let me go to my notes for that. And Zach, please feel free to jump right in. Out-of-pocket spending is a composite indicator that is pulled from the Kaiser Family Foundation's state health facts. So we were able to pull together different categories that were important to this population, but that indicator cannot be disaggregated and is not specific to older adults. And the data that is most recent comes from 2014.
Oh, all right. So that
Yeah.
helps a lot. Thank you.
And Marie, this is Zach. It comes from the National Health Expenditure data. So it is severely, lagged. And yeah, there's
Okay.
quite a few weaknesses for using it in an action plan to monitor progress.
Okay, so now you can remind me with the same sentence or two on prescription drug coverage and affordability.
Sure. So we had two indicators for that one. I will go back to that slide so you can see more easily.
You must be the only visual learner here.
Absolutely not. I'm the same way. So we had one indicator around coverage in general and then one around prescription drug spending. The coverage indicator came from America's Health Ranking Senior Report, but was discontinued in the 2020 report. So we need to find some other way to measure prescription drug coverage. The drug spending indicator. Oh, go ahead, Zach. Were you gonna say something?
Yeah, I just wanted to, the America's Health Rankings report had done an analysis of the Medicare enrollment data, and they're just no longer doing that analysis. So it would just be a matter of kind of finding out what numbers they were using to generate this percentage, and then either recreating that or identifying another source.
Got it.
Thanks, Zach.
And then the second indicator comes from Kaiser Family Foundation's State Health Facts, and it's great, but it can't be disaggregated because it's about per capita spending across the whole population.
And this is
Okay.
also the 2014 data too, so.
Okay, thanks.
So all that being said, does anyone have strong feelings about one that they'd like to advocate for before we go ahead and vote, or any other questions about the outcomes or indicators we presented here? I'll go back to the list. All right, well, not seeing any other hands raised or any questions, I'm going to move it over to Alana to put up the poll. So which of these desired outcomes do you think would have the greatest impact for healthcare coverage and affordability for the SAPA? Ooh, we're tied right now, so we'll give you a couple more moments to get some more votes in. Hopefully we get a tiebreaker. Oh no, now we have a three-way tie. We'll see if one pulls ahead. All right, I think that's everyone.
Yeah, I think everybody's voted at this point, so I will put up the results and we'll see where we are. Dramatic pause.
So the majority of you voted for reduce unmet healthcare need due to cost, but it was really close between prescription drug coverage and affordability and reducing out-of-pocket spending on healthcare. Marie noted that that might suggest some ambivalence. So as we said, there's issues with a lot of the indicators in this section, but we know that affordability remains a really important issue for a lot of older adults. So we appreciate your thoughts and feedback. All right. This is our last subtopic. We're going to talk about workforce capacity. Thanks, Carrie, and thanks to all of you for your input and your expertise here. You know, this can be a bit of a slog. But this is our last one. So, okay. See if I have control of the slides. Excellent. Okay. Okay, workforce capacity. Here are the outcomes that we have to choose from within workforce capacity. Increase access to healthcare providers, increase access to primary care providers, access to mental health care providers, home care workforce capacity, geriatrician workforce capacity, and increased caregiver supports. You'll notice that some of these outcomes are more specific while others are broader, right? That first outcome, increased access to healthcare providers, is a broader outcome with clearer strategies and an indicator that measures unmet need among older Ohioans. In contrast, many of the other outcomes on this list are more specific to certain types of providers. While each of these provider types are really important, the indicators for those outcomes are not as strong, and there are fewer strategies to truly move the needle for those specific provider groups. And you'll see that as we move through. So keep that broad versus specific distinction in your mind as we walk through the outcomes and see which resonates more with you. The first outcome we'll look at is that broader, more inclusive option, increase access to healthcare providers. The indicator measures unmet need among older adults in terms of having a healthcare provider.
The indicator here comes from the BRFIS, so it can be disaggregated by race, ethnicity, sex, education, and income, which is really fantastic. No other outcomes in the workforce capacity area in its total can be disaggregated. So this is the only indicator that we would have a priority population that comes from the indicator itself. Here are some specific strategies that are evidence-based to increase access to healthcare providers. Because this outcome is on the broader side, there are more strategies available that increase access to providers of all types. These strategies can be adapted for specific types of healthcare providers on occasion, and can be adapted to reflect the needs of particular communities. As I mentioned, we also have potential outcomes available to us that would increase access to particular types of providers. Here we have increased access to primary care providers. The potential indicator here is the percent of Ohioans living in a primary care health professional shortage area. Unfortunately, this indicator does not reflect unmet need in underserved areas. Some people in these shortage areas have excellent access to primary care providers, while others don't. And as I mentioned previously, this indicator cannot be disaggregated. One strategy we identified to increase access to primary care is telemedicine. The next outcome option is increased access to mental health care providers. The indicator here is very similar to the last. This is percent of Ohioans living in a mental health care health professional shortage area. So again, unmet need really isn't reflected in this metric, and there is no potential for priority populations. And similarly to the last, the one strategy we identified here was telemental health services. Another outcome option is increased home care workforce capacity. The indicator here measures the number of personal care and home health aides per 1,000 adults age 65 and older with a disability. This indicator is a compilation of data from the Bureau of Labor Statistics and the American Community Survey, as compiled by that America's Health Rankings Senior Report. Again, no disaggregation here. For strategies in this area, we pulled a couple of employment strategies that could increase the number of home care workers. These include career technical education, also known as vocational training for high school or post-secondary students. Another strategy might be career pathways or sector-focused employment programs, things like career academies or apprenticeships. We know another issue here is that the pay of these jobs is particularly low, and the benefits aren't always available. So this would be an opportunity to elevate some of those issues as well. The next possible outcome is increased geriatrician workforce capacity. The indicator measures the number of family medicine and internal medicine geriatricians. Cannot be disaggregated. This is an outcome that we were unable to identify any clear and direct strategies for improving. It's possible that some of those broader strategies we talked about at the beginning for increasing access to healthcare professionals, it's possible that some of those could be tailored particularly to geriatricians, but they're not evidence rated for that outcome specifically. And then finally, our last potential outcome to consider is increased caregiver supports. If you remember from the survey, caregiver supports was a subtopic all on its own. It was not prioritized in the survey. It wasn't in those top 3, but it was a really close 4th. And so because family caregivers are really part of that overall workforce in caring for older adults, we snuck this outcome in here to give us another chance to discuss it. The indicator options here for increased caregiver supports include these first 2. They're from a report by the AARP Public Policy Institute. They measure the number of family caregivers in Ohio and the number of care hours provided by those caregivers. Unfortunately, this data comes from a 2015 report that was updated in 2019. It's very unlikely that it will continue to be updated by the AARP Public Policy Institute, so it would be difficult to track progress over time on either of those indicators. The final indicator option, though, is from the AARP Long-Term Services Support State Scorecard, and this indicator rates Ohio's performance on a set of policies that support working caregivers. Ohio is assigned a score based on how many of these state level policies have been implemented. The indicator is a little bit complex because it is sort of a scale rating indicator and it's about policy, but it measures some really important supports for family caregivers, like mandatory paid family leave and sick days and unemployment insurance, protections for family caregivers from employment discrimination, some really important things for those folks. So something to think about. And here are the examples of programs that support family caregivers. These are interventions that offer support with managing the healthcare needs of older adults that are being cared for, and or supporting caregivers who are managing particularly difficult conditions like Alzheimer's or dementia. So we know there is potential for impact in this area on programs that can help increase caregiver support, and I'm sure you guys know of more that you could clue us in on too. All right, last opportunity for discussion. Here again are 6 desired outcomes. Let us know if there are ones that you think are particularly strong or particularly weak. Just like with Zach's section at the front, we are going to have to jettison one of these 6 before we can vote. So part of our discussion can be which of these is the weakest and which should leave the list before we vote. So I see a hand up. Mm-hmm.
Amy, we can hear you if you want to share your comment.
Can you hear me okay?
Yeah, hi Amy.
Okay, great. So I'm from the Alzheimer's Association, and so the last facts and figures that we released earlier this year had a special report on the shortages of geriatricians by state. So there's a breakdown of that. As far as strategies behind that, a lot of it has to do with policy on increasing incentives around gearing medical professionals towards that career path. But the other piece of it is knowing that we have this shortage, what can we do to equip our primary care providers to, to be able to care for those, in that aging population bucket that are not specifically a geriatrician. So I just wanted to throw that out there. Number one, if you want to look at the facts and figures, there's like I said, a really great special report that really speaks to the need for the increase of geriatricians as well as other specialists, but really the focus is on geriatricians. And then, the strategy to increase the capacity in the primary care space to ensure those folks are comfortable dealing with the aging population.
Yeah, that's great, Amy. Would you be able to send us that report that you mentioned?
Yes, I'll put the link in the comments right now.
Perfect. Thank you so much.
Yes, I was really bummed to see that the America's Health Rankings had dropped a measure about geriatrician shortfall. So I'm so glad that you can offer that resource.
Awesome. All right, other thoughts and questions about these workforce capacity outcomes? Which do you think are particularly strong? Which do you think are particularly weak? I remember I'll just reframe like I did at the beginning. Some of these are a little bit broader, encompass a little bit more. So access to healthcare providers is a broader indicator with more strategies. Then 2 through 5 get a little bit more specific on types of providers. So a lot of those indicators aren't as strong and the strategies are shorter lists. And then we have our caregiver supports, which is kind of its own special guy. Beth is telling me in the comments that increased home care workforce capacity is particularly strong. Beth, are you willing to raise your hand and talk to us about it? Beth and I are friends, so I feel like I can put her on the spot. All right, Beth, I'm going to unmute you.
Okay. Hi. I don't know what I'm supposed to say, but I know that's like the top need that we see and we've been advocating for several years. In our space, we have we continue to lose providers, and it is because of the pay primarily. So I think that if we are going to be able to meet the needs of people at home, we have to have the capacity to have these services. So I think it's like a top immediate crisis priority.
That's exactly what you were supposed to say. That's really, yeah, that's a helpful frame.
Oh, good.
Thank you, Beth. And Steve Wagner absolutely agrees in the comments. So thanks to both of you for that input. Are there any, I'm going to move us to which one of these needs to be knocked off the list before we can vote. So anybody is welcome to raise their hand and speak to that. But I would love if everyone would type in the comment box which one they think should go first before we vote. I'm seeing one in that realm so far, but I'd like to hear from the rest of you too. Which of these comes off the list? Okay, great. Great. Seeing a diversity of answers. So if more of you would vote, that would be wonderful. So we could get a little bit of.
Haley, I see a hand up. Teresa, I can unmute you if you'd like to speak. We can hear you.
Hi.
Hi.
So just another question about the home care workforce capacity outcome. Is there, can we broaden that to long-term care instead of just home care workforce? Is there an indicator that would allow for that, or did the indicators you've found, strictly speak to home care?
This indicator is particular to personal care and home health aides. I'll leave it to Zach to talk about what else might exist in the world.
I'm sort of drawing a blank, working off the top of my head.
Just to throw it out.
I can't think of anything. If anybody else is aware of a source that might be able to get us at that, please do speak up, but I'm not coming up with one on the top of my head.
And I'll look some as well. I just know that certainly the issue of workforce capacity in nursing homes is also a really significant dire issue in Ohio, as is capacity for the workforce, and that's home care specific. So just thought I'd throw it out there, and if we can think of anything, I'll share that.
Okay.
Thank you both. So really interestingly, in the question box, I'm seeing the most votes for taking off increased caregiver supports because it's different in kind than the rest. And then also one strong advocacy for keeping caregiver supports. I wonder if, Zach, do you have a thought?
I do, and that's that we have two people saying that number one is too broad of a focus.
Yes, I'm seeing that too.
Yeah.
So, and now we have two advocates for keeping caregiver supports. So do we have any advocates for keeping on number one, access to healthcare providers? I'm seeing, oh, Marie has her hand up.
Go ahead, Marie.
I was particularly enchanted with that one because it's because you can disaggregate it in every slice of world. But yeah. I've been persuaded otherwise, so I can join the camp of eliminating that one because it's too broad. Okay. All right. Yes, it is the prettiest indicator, but we don't need to be driven by that. We can pick different things.
And
All
I
right.
just want to acknowledge, thank you so much for bringing that up, because that's such an important point, Marie. But I think I said earlier on in this process, you know, when we try to stratify data by age and other demographic factors, it just becomes really difficult to get reliable estimates. So we have talked about using other ways to identify those priority populations, so that we're not losing that focus on health equity in the report. So thank you
Yeah,
for bringing it up.
absolutely. And it's not something we will be very focused on keeping that focus in. All right, Alana, we need to adjust our poll. So let's remove increase access to healthcare providers, that very first option. And we're going to replace it with increase geriatrician workforce capacity. And Alana's going to work on that in the background. And then if you all have any additional information, reports that you think we should look at, I'm hearing energy around caregivers, home care workforce, primary care. In a lot of these areas, we struggled to identify a wide range of strategies to improve these outcomes. If you have any thoughts about that, sources of strategies or strategies you know about that maybe you're implementing or working on, that would be great information to either email to us or to drop in the question box so that we have that. We'll be looking for your help and expertise on that after today as well. All right, thanks, Beth. I'm seeing some feedback on that, so I really appreciate that. If others want to drop things into the question box, that would be great. All right, Alana has our poll ready, so we're going to throw this one. All right, which of these desired outcomes do you think is most important to prioritize in the SAPA? All right, you guys were very decisive. We have a couple more people that need to vote still, but most of you have. I think we have one more person, so we'll just wait a couple seconds. All right, I think everyone's voted who is wanting to vote. So let's close that and throw those results. And we're seeing the most energy around the home care workforce. So thank you all for that feedback, and we'll be in touch again about how to best frame and indicators and all of that. Okay.
Yeah.
Do you have a thought, Zach?
No, I just saw that Teresa typed into the questions box again about this idea about broadening that to long-term services, and I just wanted to let her know that that's heard, and we're going to be looking for those indicators and thinking about doing that.
Okay.
Thank you.
Great. Awesome. Wonderful. All right. So we're just going to close out today with some next steps. What comes after today's meeting? If I'm able to control my slides. Wonderful. Okay. That's okay. Alana, do you just want to do it for me? Just move me to the next slide, the working slide.
Go ahead.
Okay. Yeah, next slide is fine. We have a busy summer ahead of us. So today concludes our first round of work team meetings. So thank you all again for your participation. This has been fantastic, and we've made a lot of headway in this first round. The work teams will be meeting again in early to mid-July, and you guys have received the calendar invites for that at this point. Those meetings will be to provide additional expertise on target setting and those evidence-informed strategies that will be elevated in the SAPA to get at these outcomes that we've talked about together. We're grouping in bigger groups for those meetings. So all the priority outcomes will be together and all the priority factors. The schedule for those are here. They're also on the HPIO SAPA page. And like I said, you should have received the calendar invites. If you're interested in joining another work team so that you can provide more expertise in any of these areas, please feel free, let us know, drop that in the question box or send us an email and we can get those invites out to you. Also, we'd love for you to be thinking about other stakeholders that we should be reaching out to bring additional expertise on target setting or strategies in particular for these topics. So if you have suggestions of other work team members that we should be inviting to these meetings, please let us know that too in either the question box or via email. Next slide, Alana. We know that identifying a strategic set of priorities to focus on in the SAPA is really difficult work. So this is our time to just pause and say thank you. Thank you for being a part of that with us. The webinar recording for today and the slides for today are going to be posted on our SAPA advisory committee page. So for folks who were not able to join, or if you want to reflect on anything that we discussed together, all that stuff is posted. Next slide, we're just going to pause, and here's where I wanted to pause and thank you for being a part of this and getting us to a place where we can come up with a concise set of priorities for our state and our local partners to work together to improve the health and well-being of older Ohioans. This is a worthy goal, and we really appreciate all the work that you guys do on this every day and the work that you're doing to inform us on this project as well. Next slide, if we just want to give you the opportunity to ask any final questions that you have, you're welcome to do that. We'll stay on the line for another few minutes. But if there are no pending questions and nothing else that you want to share with us in the question box, we'll say thank you for your time today, and we look forward to our continued work with you over the next few months. So thank you all, and we'll see you soon.